afternoon, everybody. I'm Jackie Smith, Chair of BHRUT, and very pleased to welcome you to today's board meeting. Also, very good to be joined today by Marie Gabriel, who is the Chair of the North East London Integrated Care System, who is observing the board meetings in the system. Also, very warm welcome to Anne Hepworth. It's Anne's first board as Director of Strategy and Partnerships, having joined us in February, so you're very welcome, Anne. And also a warm welcome to Helen McKenna, who is joining us on her second day in the role as my Chief of Staff. So everybody is very welcome, and we will start, as we always do, with the our patient story. And Victoria, I think you're going to introduce that for us today, aren't you? Thank you.
I will do. Thank you, Chair. So usually I bring stories to board which are positive or that have got a mixture of positives and negatives. But actually what we know is that we get an awful lot of learning from the complaints that we received in the organisation. So this month I brought a story that relates to a couple of complaints that we were receiving the middle of last year to do with access to CT scanning in the organisation. I was supposed to be joined today by one of the patients that made a complaint, but unfortunately she's not arrived, and we're checking into what's happened to her at the moment. So with agreement, Chair, I'll read out the complaint letter and then I'll hand over to my colleague Layla, who is the cross-site CT lead radiographer, to talk a little bit about the learning from that complaint and what we've done in response to that.
Victoria, can you help us to shift if you think she's likely to come, shall we shift the agenda around a bit so that we can hear from her when she arrives?
She's quite an unwell lady, so we're just checking whether anything has happened with her health that means she's not able to attend. So I think it's going to be unlikely at this point.
Well, I'll tell you what, why don't we do the first bit of the agenda?
Okay.
Then if she does arrive, great. If she doesn't, do as you proposed and read out her letter, and we'll do it like that. Okay?
Yes, thank you.
Okay, good. So let's move on then. We've done my welcome. Apologies for absence. We have apologies from Ruth Crowley, from Alex Hamilton, acting coup, and from Alan Wishart, interim director of workforce. We've got the update on the Board of Directors declarations of interests and the whole set of declarations in the papers for people. So that's a declaration from Anne, obviously having arrived, and an updated declaration from Ben and from Caroline Roberts, Associate Ned. So let's move on to the approval of the minutes from the previous meeting then, which was the meeting that we held on the 11th of January. And I will go through a page at a time. So for any corrections or issues as we go through, if you put your hand up, I should see you. So page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, 12, 13, 14. Good. Okay, we will take those as a correct record then, unless anybody shouts now. No. Okay. Good. Matters arising from the previous meeting. Nobody identified anything at that point. Is there anything? We have one action due on the action tracker relating to the Maternity Services Serious Incidents report, which, Catherine, I think you were going to update on.
Yes, we've looked at this, and this is quite difficult for us to do, so we are looking at it, but I wonder if I could bring it back in a couple of months, because I think we're going to have to do something slightly different with the way that we're reporting them, and because we're moving to the PSERF system, I wondered if we could tie it all in with that.
So this was the issue around how we categorised people who were of high risk in order that the trends could be identified. And it seems, I mean, assuming that we can do it in a reasonably quick period of time, it seems a good idea to also link it in with the PSERF, which stands for Patient Safety Incident Reporting Framework, I think, doesn't it, Catherine? Very good. Which we also want to make some quick progress on. So, okay, let's keep that on the action log and make sure that we bring that back to board as soon as possible. And we may give it some discussion in a seminar as well.
Thank you.
Okay, good. And the other item has been completed, which brings me to my report. And first of all, I would say Happy International Women's Day to everybody. Particularly important for us, of course, where 77% of our workforce are women, and we want those women to be able to work to the best of their ability, to achieve, to get on, and to do the really crucial work that they are doing, supporting patients and their colleagues. And there are lots of very good and interesting events that have been organised in the Trust by the Women's Network and others this week. So I hope we were able to take part in them, which is great. Secondly, I wanted to say something about Ukraine, and obviously all of our thoughts will be with the people of Ukraine at this enormously difficult time. And I was very heartened by the fact that I did a staff briefing on the first day of the invasion, and one of the first things that people said was, what are we going to do to support our staff who may be impacted by this? And I'm pleased to say that both a small number of Ukrainian staff that we have working in the Trust, who obviously will be enormously worried about what's happening in their country, have been identified, as actually also have the small number of our staff who are of Russian nationality. And of course, it's very clear that this is not an action supported, I suspect, by large numbers of the Russian population, who will also be very worried about the impact on them and their families of the action being taken. And then we also have a large number of colleagues whose nationality or place of birth is in countries that border Ukraine and Russia. And these have been identified. We've talked to line managers, and we're making available support, both obviously through line managers, but also for our wellbeing advisors, through psychological support, through the chaplaincy, guardian service and occupational health. And we will certainly ensure that we recognise the pressure that they face and continue to care for them in an appropriate way at a very difficult time. Just a very quick comment on the pandemic. It's, of course, any of us, and we all venture outside the hospital and the Trust at different times, and read the news, will know that in many ways people are seeing the end of the pandemic in terms of the lifting of the restrictions and the return to some of the freedoms that we've lost. We know within the trust, of course, that we continue to treat people with COVID, we continue to treat people with the long-term effects of COVID, and of course we have the challenge of the recovery in terms of those people whose care has been put on hold because of the way in which we needed to organise our services during COVID. So it is very far from over for our staff, and I would just like to put on record that we recognise that for our staff, and also to thank them for their continuing enormous efforts during the course of the pandemic and work that they've done to support our patients and each other, and thank you very much indeed for that. The week before last, Olwen Williams, the CEO at BHRUT Health, announced that she will be retiring from the end of July after a over 40-year career in the NHS and 7 years at BHRUT Health as CEO. And that obviously meant, given the success that Olwen has helped to lead in the collaboration and the work, the very good work that is happening between the two trusts, that we needed on both of the boards to think about what the implications of that were for the future leadership. And we decided that in order to both maintain the progress and the momentum of the collaboration, but also to ensure the stability and support for the leadership, both not just at BHRUT Health, but also here at BHRUT, that we would look to recruit a CEO who would have responsibility as accountable officer across both BHRUT Health and also Barking, Havering and Redbridge. Their role will be obviously being accountable for leading both of the organisations, but actually in much more of a sort of strategic system leadership role. And Matthew will remain in his role as our Trust Chief Exec, reporting to this board and accounting publicly as well. And his exec team will continue the very important work that Matthew has been leading them in running King George and Queen's, and continuing to drive the improvements in both quality and finance that this board wants to see. And I have briefed partners and also took part in the staff briefing in order to talk about that, and we'll continue engaging with people both as we go through that recruitment and as we develop the collaboration, so that people are clear about the way in which we're taking that work forward. We had some good events in the last few weeks with the official opening of the £7.5 million ITU here at Queen's Hospital. Andrew Rossendale, the local MP, and colleagues from Havering Local Authority joined us in order to do the official opening, and we had Vin Dewaka, who was at that point at NHS London, now with a national role, coming to open the ambulance receiving centre in our emergency department as well. And finally, I've had some good meetings with a range of people. I've met with, had one of my regular meetings with the staff side representatives here at in the trust, where amongst other things, I thank them for the support that they'd provided during the very difficult period of time when we were contemplating the mandatory vaccination requirement for our staff. Fortunately now no longer directly with us, although I think the impacts continue. I will be attending the Outer North East London Overview and Scrutiny Committee with Matthew on Thursday, and the Redbridge Scrutiny Committee tomorrow. And I also met with representatives of Health Watch across the three boroughs that we serve, and we had a good conversation about the work that they do to represent and our patients, and to work with us on improving patient care. So that's my report. Are there any questions from anybody on that? Let's move on to Matthew and his Chief Executive's report. Thank you, Matthew.
Thanks, Jackie. Can I just check that you can hear me okay? Smashing. Right, thanks everyone. So a couple of updates from me, further to those which you've got in my report. And just to say, first of all, the first patients who are being transferred into our new Jubilee Critical Care Unit are being transferred across tomorrow. And I was there yesterday talking to a number of the team there who, and we're just in the process of handing out some of our 20 and 30 and a small number of 40-year long service awards. And there was a lot of staff who weren't able to get them during the pandemic, and I spoke to a group of those staff who are going to be working on the new critical care unit. And actually, do you know what, their excitement about working in such a good clinical space with so much light and such a fantastic feel to it was really palpable. And it was interesting hearing from them about what it means to them actually to see that the trust investing in them in this way. And it's, you know, it's not hard, you know, it's not hard to underestimate the impact that this has on people. But when you're coming in and doing a shift in an environment like critical care, knowing that the trust is able to provide such excellent facilities is wonderful. And I'm looking forward to seeing the impact that has, both on the staff and on the quality of care we're able to deliver. Talking about quality as well, we had published last week a CQC report into our emergency department at Queen's Hospital. This was part of a different way of working CQC are trying, where they're looking at whole systems and looking at the interplay between an emergency department, local primary care, the urgent treatment system, community services, care homes and others. We were, I think, the last acute trust in the country to be inspected before they suspended their inspection process for the winter. But I have to say the inspection was carried out in a very effective manner. It was an expert team who were very good to work with, and their professionalism and their understanding of the emergency department pathway really came through, and I think gave our ED team a lot of confidence to speak to them very openly. If you read the report, and I think it is well worth a read, both our report and the system report, they're very positive about the leadership and the culture within the department. They're positive about the way in which the staff are dealing with very significant levels of pressure on the department and how they're managing safety and risk in that context. But they're also clear as well that the weights that people continue to face in our areas are unacceptable. I think what's helpful is that that is put in the context of a system where people are also struggling to access other forms of care due to the pressure there is on across the whole system. And if you read that whole system report, it does give quite a visceral picture actually of a system that is under enormous pressure. The most visible place in which you can see that pressure is our ED, because that's where people can turn up 24 hours a day, 7 days a week, and that's where you see the ambulances waiting and the queues happening. But that is consistent with the system pressure they're able to find. Me and a couple of members of the ED team presented some of our feedback on this to the CQC board, and we'll be bringing more information on this through Quality Committee and through this board in due course as we get to grips with some of the challenges they've set us about improving things. And this week, at Queen's, Kareem, Naz and the team are running a pilot, well, it's more of a proof of concept of a new model of same-day emergency care in Queen's. It's on day 2, but it's bringing together our emergency medicine, acute medicine and specialist medicine and surgical colleagues to really try to improve flow through the ED at Queen's. We've been able to do that because we've been able to close COVID majors there, so we no longer have an area designated for COVID patients. And that's given us the space to try this new flexible way of working. I'm really hoping we start to see that having an impact, and it's off to a good, strong start. And in 2 weeks' time at King George, we'll be opening our new 12-bedded observation area and our rafting area as well, rapid assessment and treatment area at the front door as well. So there's more capacity coming on within the emergency department. We have been continuing to try to recruit staff for Sky Ward, which will be freed up by the critical care build, to give us some extra acute beds at Queen's. I think at the minute, due to the lack of staff in the system, we're probably going to be constrained to 10 beds of the 30 available there. And our colleagues at North East London Foundation Trust have been trying since January to reopen the Daisy Stroke Ward, which would decompress our stroke service that was shut at the start of the pandemic. Again, they've been unable to staff that. So again, due to the lack of workforce, we continue to see these pressures on the most acute points of the system. And that, I'm afraid, is going to continue to be a story this year, where we are in a position where actually we might have the physical space and we might have the beds, but they're no use without the folk to staff them and oversee them. So I've been talking to some of the teams about how we perhaps think a bit differently about our plans for next winter. If our plans are more hospital ward beds and the staff aren't there, then those plans aren't sustainable, and we need to think a bit differently and be prepared to try something different. And unfortunately, this being the NHS, March is about the right time to start thinking about winter, because we have a 3 or 4 month grace period before annual leave kicks in, and then we're right back into it all again. And so we're going to try a few things out this year, and that CQC report actually has been a really helpful catalyst for some stronger system working and thinking about that. And it is, as Jackie mentioned, International Women's Day, and I think it's really important that we as a trust reflect on that and what it means for our workforce. I think we've had a significant conversation in the NHS in the past 2 years about race and about the experience of colleagues from different ethnic minority backgrounds and their experience of racism and discrimination. And there's also been some really interesting developments recently, particularly looking at sexism as experienced amongst surgical and medical trainees. There's been some very interesting work done by the British Medical Association. Royal College of Surgeons is other, and the Royal College of Surgeons, I have to say, has taken a real leadership stance on this. And it's something that the board will hear more from about this year as we work our way through what we can do to improve the experience of our trainees and make sure actually across all our professions that we address concerns about the way women are treated in the trust. So International Women's Day is today, but we couldn't run anything in our hospitals without women in the workforce, and we really need to make sure that their experience of working at BHRUT is improved based on the feedback that we've had. And finally, it's 2 years on Friday coming since the WHO declared the pandemic. And the first COVID death in our hospitals was on the 13th of March 2 years ago at King George Hospital. And we'll be having a memorial service this Friday. And there's some information on the internet about that just to mark that 2 years. And that'll be at that starting just before 11 o'clock this Friday morning. And it's interesting, you know, Jackie mentioned the contrast between the wider world now, where I think you can largely go about your business without particularly having to think about COVID now, and yet you come into the hospital and we still very much need to observe good practice around mask wearing and hand hygiene. And thank you to Soph, who shouted down the corridor at Peter Hunt and I today for going yellow zones at King George without taking the appropriate steps. She was absolutely right to pull us up on it. And we have actually seen in the last couple of weeks that we've lost bed capacity in some parts of the trust because people have been failing to do the basics of good hygiene around hand washing and mask wearing, and that very much is going to remain with us. There is a gear change now when you come from outside into the hospital, and I know our security staff and our other staff are reporting an increasing level of abuse around that, which is something we are not going to tolerate and going to continue to make sure that we address very strongly, because we have vulnerable people coming into our hospital who need protection from ongoing viral infection, and we also have staff who are still coming down with it as well, and we need to make sure that we take all appropriate measures to prevent that spread. So that memorial service is this Thursday in the morning, and there's more information on the internet and intranet about that. So that's everything from me, but there's plenty also in my update, and happy to respond to any points about what I've said today or what was written. Thank you.
Thank you, Matthew. Questions or comments from board members on that? Okay, Victoria, let's go back to the patient story. I don't know if Mrs. Print has been able to arrive, but if not.
I apologise, Chair. I've been advised that she won't be able to attend today.
Could you send her our best wishes as well?
I will do. Thank you.
And let's do as you suggested and hear the story from you and the response as well.
Okay, so there were a couple of complaints about the same subject around the same time, but I'll read Mrs. Print's complaint. First, I must stress this is not a complaint about the staff at the unit. I had an appointment for 3 p.m. scan to arrive at 2 p.m. for preparation. I arrived at 1:45 p.m. and was taken down for the scan at just before 2 p.m. There, along with 3 other patients, we were told to wait in the corridor, and there I sat for 1.5 hours. It was a very cold day and it was freezing cold sitting there. I understand about the delay, but why leave us there and not in a room away from all the people constantly going past us? I am 73 years old. I have heart problems and I'm in remission from cancer. And since COVID, have only been out for medical appointments. So I found it quite stressful being amongst so many people. Because I was so cold, my veins were not visible and there was a problem getting the cannula in my arm. Surely patients could be sat in a room somewhere warm and not in such a very busy area of the hospital. I await your reply. And if it's agreeable, Chair, I'll hand over to Layla to talk about some of the things that we did in response to that complaint and the learning that there was.
Thank you.
Good afternoon, everyone. So I phoned the patient and kind of got the feedback directly from the patient to try and work out what we could potentially do to improve it. So what we found was we kept the patients in the main department for longer, so that they were in an enclosed area where they didn't have sort of all the draft from the open corridor of from block 1. And then we took them down to the unit close to the time when the scanner phoned and said, OK, we're now ready for the next 2 patients, so that one would go on the table and there'd only be one waiting outside, and it'd only be for about 10 minutes. But not last weekend, the weekend before, we've moved that whole unit over to Barking as part of their CDC project. So now we're asking patients to, when they arrive, that they go directly to the unit as well, so they're not walking all around Barking Hospital trying to find places. And if we need to, we get them to wait in the car, and then we'll give them a call when we're ready. If they don't come in the car, then we're able to keep them inside Barking Hospital and go and collect them from there.
Lena, have you finished?
Yes, unless you needed me to add any more, sorry.
No, thank you. There will be some questions. And CDC, Community Diagnostic Centre. Yeah. Today, my mission is to challenge acronyms. so be afraid, be very afraid as we go through this meeting. Good. Are there any, Lena, can I just check and reinforce? So when we received the complaint, you rang the lady in order to talk to her
Yes.
about it. I mean, my view is that that's exactly what we should do when we get complaints, not go through a sort of tortuous lengthy process. Of course, there to be a sort of official response to complaints. Is that something that you would normally do when you receive that type of complaint?
Yes.
And it's something, Victoria, we encourage and promote, is it?
Absolutely. We know that by picking up the phone, we can minimise some of the anxiety, some of the distress that complainants are facing. And it just enables them to realise we've received your complaint and we take it seriously and we've listened to you. So we absolutely encourage that. With this particular complaint as well, Chair, just to say that she had to have another scan week before last, and she's written another letter, which is glowing, an absolute compliment about the change in the service and the experience that she had second time round.
Good. Well, that's very encouraging, and as it should be. Good. Catherine, did you want to say something?
So I was just going to mention about the phoning people. ED have lots and lots of complaints, and they've particularly around the waiting times. And over the last 4 to 6 months, they've started to phone people, and it's really reduced the volume of complaints, because actually people are able to speak to a human being, explain what their problem is, and you're able to have a conversation. So that's made a big difference, actually. So I think that I, like Victoria, would always recommend that people phone and speak to people. We sometimes have complaints that come through the Chief Executive's office or through mine or Magda's office. And again, we phone the relatives, and it makes a big difference to them. I think they do believe that somebody's listening and taking it seriously.
Great. That's very encouraging. Good. Are there any other comments or questions on this patient story today? Leila, thank you very much for coming and talking to us about the action that you've taken, and most importantly, thank you for taking the action. Joan, let's go to Joan.
Yeah, it's just 2 quick questions, and thank you for the story of the lady who really has impacted the way we do things. The 2 quick things would be, what COVID really did slow down our response to complaints. We know that because of the nature of the pandemic. Are we getting back to that median time where we do contact people within the time scales? And that's probably an easier one, but hopefully we are back there. It's not just a one-off. We know what the team was working on that, so it'd be good for the board to have that assurance. And secondly, is there something in the way we operate that can help us enable staff, empower staff when we see something, when there's frenetic activity, we're all trying to do our best, but when we see something that just doesn't look right, somebody waiting outside 75 or, you know, in a cooler area, when the pressure is on, and I really get that, is there some way we can encourage staff to just tell us, let's fix it, you know, want that kind of campaign. And that staff may be a very not senior member of staff, but they can see that something needs fixing. Do we encourage that? You probably have thought about that already, Victoria or Leila.
Can I answer the question about complaints first, Joan, if that's okay? So yes, we are getting back to where we should be with complaints. We're not quite there yet, but fully expecting that by the end of March we will be there or thereabouts. We're answering in a much more timely manner. Our response rate is increasing month on month. So yeah, I would say that we are getting back on track with that. We've got a lot of plans around how to do that. In terms of your second point, that's really interesting. That's definitely something we should be doing. PALs do that a lot when they're out and about, but it's we then empower others to do it. I think I need to go away and talk to some colleagues around how we can put a bit of a campaign together to get that message out, if that's okay.
Thank you.
Good. Richard?
Thanks, Jackie. Just the other point to add, I think in conjunction with Victoria, I guess we're very aware that a lot of patient contact is in relation to, I suppose, growing waiting times for elective appointments. So one of the things we'll be putting in place imminently is a specific line for patients and for primary care to contact us to find out where they are in terms of their pathway. And it will also have a knock-on effect in terms of hopefully releasing capacity within PAL's team to focus more on complaints rather than just queries about where patients are. So hopefully that will have sort of two benefits.
Good, thank you, Richard. And how quickly do you expect that to be up and running?
I'm hopeful it will be within the next couple of weeks.
Good, thank you. Right, all right. Well, thank you, as I said, Leila, for that. Thank you, Victoria, and please pass on our best wishes to Ms. Sprint about and to thank her for the feedback that she's provided. Let's move on to the quality and safety section of the agenda. And first of all, we've got the report.
Thank you very much indeed. And this report is brought at the specific request of NHSC, NHSI. You'll remember that Donna Ockenden published her report about a year ago, and the second report is being published towards the end of March. In preparation for that, all boards are asked to review the work that we've done around Ockenden, but also to look at the Morecambe Bay report, which was published obviously about 5 years ago, and also Birth Rate Plus. So what we've done in this paper is really talk to the work that we've done and the position that we're in. Because we had our CQC inspection and we were downgraded to requires improvement, we become part of the maternity support programme, and you'll see referenced in the paper Dr. Marie Lewis. She's our support during this period of time, and we're expecting her to be with us for about a year. She's reviewed our action plans, which are detailed in the appendixes, and also this report. So it was really helpful having her on site and having her able to do that for us. The Ockenden Report action plan came through Quality Assurance Board and also through Board, and was then reviewed both nationally and by London. And we were pleased to find that our results are better than some of our local trusts. So we scored 70%, but our nearest neighbours scored 60%. So that's really good. I don't have the national benchmarking data because the national benchmarking data isn't available yet, as far as I understand. But I think that just to give a bit of a reference point for the board, we're obviously in the right sort of area in terms of the things that we're doing. In terms of our Morecambe Bay report, we did a lot of work on that when it was first published in 2015-2016. We completed our action plan, which was green when we completed it. As part of this review, we were asked to review it again. We have reviewed it, and we now find that some of our actions are amber. So I think there's some learning here for me, which is about how do we review reports and action plans related to reports going forward. So we're going to look at all the reports that have been published, not just for maternity, over the last 8 years, check our action plans and check where we were green previously, but we are now green, so that we can perhaps keep that going on a rolling basis. You'll note that a lot of the amber actions on the Morecambe Bay report relate both to training and to leadership and governance. And you'll know from the previous reports that I brought to this board that our leadership team has changed and is changing. We've now been able to recruit to our full leadership team, which we're really pleased about, and they will be coming in and will be in place over the next couple of months. We've worked very closely with Kate Brinkworth, who's the regional maternity lead, and she is happy with our appointments and content that we've appointed the right calibre people. So once they've started to embed and are working with us, we're hoping that all of our governance processes, our training and education that are highlighted in here will be back to where they were a couple of years ago. But we will continue to monitor that through our maternity assurance group and also through the maternity safety champions meetings. We undertook the maternity self-assessment tool and that was also presented to board, and that continues to be monitored by both those groups that I previously mentioned. We've also undertaken our Birth Rate Plus review, and that's been reported to board on a number of occasions via the Chief Nurse Staffing Report. Marie has asked that we review that and look at our continuity of care. At the moment, we have one team of midwives who provide continuity of care, but she's asking that as we develop our service and provide a more equitable service, we start to extend those teams. So we'll do that, and that may well result in us requiring more midwives, because to do continuity of care, that means that we need to have the same midwife looking after women, both antenatally, postnatally, and when they deliver. It's slightly more labour intensive, and all maternity units are really struggling with having the capacity to do this and having the midwives to do this. At the moment, we've increased our number of midwives in training, so we now have 2 cohorts that come into us. We've just been offered the opportunity, along with everybody else, to go to a shortened maternity training. You used to be able to train as a midwife. If you were a registered nurse, you used to be able to undertake an 18-month programme to become a midwife. That stopped and it went to direct entry, so you had to do 3 years training. We've now been advised that there are going to be places for people who are registered nurses to do that training in 2 years. So we're looking at people in the organisation who might want to train to be midwives to do that, to further enhance our Grow Your Own workforce for the future. I think that I just wanted to reiterate that all of the actions, both for these plans and for all of the other PSAP plans that I presented through QAC and through board, are continuing to be monitored through the Maternity Assurance Board, and Marie is joining that board for us. So I'm very happy to take any questions.
Thank you. Questions or comments on
Yeah, thanks for the information. Catherine, I know we're working at speed, so I didn't actually see the report. I think we're going to try and work on having that, but just a couple of questions from me, and invariably that the team has kept going and delivered a service with increasing pressures is something I think the board would want to know and appreciate. Particularly with the rising complications that women are showing, and that isn't just a recent trend, that's been a trend before COVID. So I suppose just 3 things. I know we've got an interim director coming on board. When do we think we can have an actual director? We tried going out for that post and it was quite difficult. So the interim coming is good. When do you think we'll have a full-time director? And then also something about the diversity of your leadership team, just making sure ensuring, I think we're over 50% in this trust who are diverse members of staff. So something about how we're doing on that would be good. And back to the substantive issues, I think the peer-led approach that you brought in is really helpful in thinking through our plan. Are there any areas where we are not on par with others in the area, just any areas by exception that you may not have highlighted in the plan? I think at BHRUT, we don't want to be the lowest in the pack. So if we're the lowest in the pack across everywhere, we're doing the same as our other peers. We wouldn't want to be doing that. Your push for quality has always been consistent. So just knowing where we might be an outlier would be helpful also to the board.
Okay, thanks very much indeed. So the director of midwifery is quite difficult. So for those, Jane is quite well versed in this because of being the maternity safety champion, but we've been out to recruitment, or trying to recruit our director of midwifery probably for about 6 months now. And a number of large trusts in London went out at the same time. So we weren't able to get a field of strong enough directors of midwifery, and that was supported, as I say, by the regional nurse. So you might remember that we put £500,000 into maternity as a result of Ockenden 1 because we wanted to really strengthen the governance structure, and part of that strengthening was to put a head of midwifery for governance in. That person is in post, and that person is a permanent appointment. We also had a head of midwifery for ops. We recruited to that post on a permanent basis. When we were unable on the sort of third attempt to recruit to the director of midwifery, I felt the sensible thing to do was to offer a secondment opportunity to both of those heads of midwifery. They both applied and were interviewed, and one of them, called Abby Jidoa, was successful in getting that post. So she is going to be the interim director at midwifery for 1 year. She has a big support package around her in terms of education and training, so that we're very hopeful that when we go out to advert, probably in September or October of this year, she will be in a position to apply for that post. So we're trying to grow our own in the way that I've described before. In order to backfill her, we've had to recruit somebody as a head of midwifery operations for a year, and that person is joining us by the beginning of May. So although it feels like they're quite interim, they're quite long-term interims, and we've got a plan in terms of their development. So they're not jobbing consultants, they're not jobbing interims, they're people that we think have potential, so we've brought them in to really support us in that. And in terms of diversity, they're quite a diverse team actually. We've got Eastern European and Black African and white in there, so it's quite a variety of people in that very senior midwifery leadership team. In terms of where we are an exception in terms of our quality, there isn't anywhere where we dip below everybody else. We're in the middle of the pack for lots of things. The area that I think we would have concern around is our induction of labour. And we've already been talking, Abby started yesterday, she's been to see me, she thinks there's a different way we can do induction of labour, which would be better for our women. So I think that we would expect to see quite a lot of changes over the next couple of months, because she's new to the organisation, she's come in with entirely fresh eyes. She saw me at 11 o'clock and had a list of about 10 things that she thought needed changing. So I think we're probably going to see a bit of pace around the changes. So does that answer the questions, Joan?
Yes, thank you.
Sue.
Thank you, Chair. Catherine, thank you for some very detailed and triangulated reports, and I think the areas of development are well articulated. I know that historically we've been looking at increasing number of births in our locality, in our catchment, but I note in the report that numbers have gone down, and that's actually why we're able to handle the increasing complexity. So I just wanted to ask a future looking question about where do we think our trajectory for numbers of births is going to go now, and what might that mean for our finances, and have we made sure we factored it into future financial planning? Thank you.
Thank you. So we thought in 2019, towards the end of 2019, that the birth numbers were going down, and we thought that was perhaps related to Brexit because we have quite a large European population. But then, of course, we hit COVID, so we have no idea actually why our birth numbers have gone down. We don't know whether it was related to COVID or Brexit or whatever, but they have gone down. Given the level of building that surrounds us, I can't believe that our numbers aren't going to go back up. And I did, I think in last month's report, say that I think we would need to come back and ask for additional staff once our numbers start to go up. So I think that we should be expecting that. At the moment, we don't have, obviously we tend to have about a 6-month lead-in time because there is a lead-in time to having a baby. But at the moment, those numbers aren't going up, but we are keeping a very close eye on that. And as soon as we get, as soon as we're aware that those numbers are starting to consistently go up, we will be coming back, yes.
Thank you.
And Linda van den Hende as our patient partnership representative.
Yeah, thank you, Chair. I'm very aware, obviously, that there's a Maternity Voices partnership that operates within the maternity group, who I have had some limited contact with. But I'm just wondering whether or not there's anything that we don't have a patient partner assigned to maternity at the present time, as you will know, Catherine. I'm just wondering whether there's anything that we could do in a what I call a blitz way that would support the experience of patients. I'm very aware that the FFTs are quite low, I think, in some of the maternity areas, and I know that that's, you know, there's sort of the neonatal, etc. There's several sections, but I am aware that there is quite a low response. I'm just wondering whether there's anything that we can do to actually improve the knowledge that you may have about the actual patient experience that's beyond the Maternity Voices Partnership, which I know operates in a very different way to what we do. Thank you.
I think that's a really helpful offer, actually. We do the ward assurance programme, which we've been doing on the wards. Our next part of the programme is maternity, actually. So I think it would be really helpful if we could plug you into that. So if I could, Tracy, who leads on the ward assurance programme, to contact you, I think that would be really helpful, but not only for that programme, but also preparing for it, and because you know you come in and do those anyway, and then what do we do going forward? I think that would be really helpful.
Okay, thank you.
Thank you.
And sorry, FFT of course stands for Friends and Family Test. Let us move on then to the report, and there are 2 meetings that have been held since the last board, and Mehboob will report on the January meeting, and Jackie, I think, will present the highlights from the February meeting. So Mehboob first.
Thanks very much, Chair. The meeting I chaired was co-chaired with Caroline Roberts as well, so it just goes to show it took 2 of us to do Jackie's job. The bits to highlight is, first of all, on learning disability deaths from COVID-19 and the learning from that, because as you probably all are aware, it's looking backwards to the start of the pandemic and then up until March 2021, during which period 41 deaths sadly occurred in our trust, and a full structured judgment review was carried out on each one of those deaths to ascertain the levels of care and any other issues that of clinical input which could have contributed to those deaths, and whether the deaths were preventable. And just to put it in the sort of national context, ONS data published in February 2021 showed that around 65% of those with a learning disability who died from COVID in the first wave had mild or moderate disability. And last week, when we received the agenda papers, I sort of looked up to see what is the current situation, and quite alarmed to read that in the 18 to 34 year group, data from Public Health England shows that for those with a learning disability compared to the general population of young adults, they are 30 times more likely to die from COVID. And some of the analysis and the assessment from that shows that the messaging around vaccinations, etc., are not getting through to that particular group in society. So at the committee, we concluded that the evidence presented to us and the assurance given was that in the first wave, communications could have been much better with those patients who had learning disabilities, and also with their friends, with their family and next of kin. And actions have been put in place, not just by our trust, but nationally, to improve the situation for those category of patients. Might I just add that also, from my experience, we have a real strong and robust approach towards supporting patients with learning disabilities, and our business as usual services really do take into account their needs, and it's done in a way that meets the expectations that as a board we would have of our staff. The other item that we considered in quite detail was the digital strategy, presented by an enthusiastic digital strategy managers who were really engrossed in this work, and I can tell they love their job. They have a huge program of implementing a digital strategy across the trust. We are not a forerunner on digital. We are running to catch up with other organisations. So, for example, our electronic patient record system is still in the implementation stage and has not been fully embedded in the organisation. There are a number of risks that were highlighted, which the digital team are working to address in a sequential order in order to improve patient quality and safety. We've got too many paper-based systems which are staff intensive and not very efficient, and neither are these systems talking to each other and sharing data about patients along the patient pathway as well as we would want that to happen. The point, I guess, to finish off on that for us all to be aware of is because it's a large program which has not just digital at its centre, but OD and other change programs running alongside. It's something the board needs to be aware of because of the complexity of the program and its kind of cross-cutting implementation across the organisation. If we get it right, it'll work really well for us, reduce costs, improve efficiency, and also most importantly, improve patient outcomes. If we don't get it right, it'll be one of those digital programs that we hear about, horror stories in the press that it cost a lot of money and didn't deliver the outcomes. So I guess what I'm asking is for Matthew and the execs just to be cited on the delivery of this programme in the near term, but also the medium to long term.
Thank you. Thank you, Mahbub. To your report, and then if there are any questions on either of them, we can take those then.
Yeah, okay, thank you. So I think the first most general point is that there were a number of papers in the meeting where it seemed that staffing levels were impacting the Trust's ability to deliver against our targets and what is expected of us. And I think that was quite a common theme throughout the meeting, and we need to understand this further in light of the overall staffing position across the Trust. So then to move on to some more specific points, back to maternity, the high level risk at 25, which had been raised at board in relation to capacity in maternity, has been reduced to 20 as a result of a number of mitigations, obviously is continuing to be monitored. A new harm review process has been introduced because of the number of patients in delayed pathways of care, focusing on those patients at greatest risk of significant harm. We did note, interestingly, in the meeting that the assessment of harm doesn't include the impact of psychological distress or loss of work time due to delays in receiving treatment. And the Chief Medical Officer agreed to raise these issues and the challenges of data sharing across the broader system. Obviously, as a result of these harm reviews, a number of patients will have more detailed clinical reviews. Another point is that the number of C. difficile cases have been rising across the Trust. We now have 40 cases since April last year versus a threshold of 32 cases. So every single ward has received training, and obviously this is an ongoing focus within the Trust. In relation to one of the points Mahbub was making about digital, a very good example which was raised in the meeting is that 15 months ago, we had agreed funding for ICNet, which is a system that helps the infection prevention team to manage cases digitally. This has been delayed for, as I said, for 15 months, which means that that team are continuing to manage the high workload on paper-based systems, as you know, a good example of Mahbub's point. And finally, two positive points. With respect to the SPC charts, which are presented in the Integrated Quality and Safety Report, Lorraine, Bess and I had a really constructive meeting with the Data Information
integrated quality and safety report.
Oh, thank you very much indeed. So obviously you have the information here, and we've been through it in quite some detail at the Quality Assurance Board. I think there are a few things that I'd just like to mention during this report, one of which is we've really started to look at our 12-hour trolley breaches, which you can see from the report are very high numbers, and we're really starting to look at, is there anything else that we can do differently there. The number of incidents have come down quite a lot. People are really working and really concentrating on trying to get this back to a normal position, and Victoria mentioned earlier on the overdue complaints should be back to a normal position by the end of March. In terms of our incidents, we're probably towards the end of April, but we can see the light at the end of the tunnel now in terms of getting this back on stream. The corporate division, it sounds like it's the executive, but it's not really. It's mainly estates and facilities, and we've had somebody working specifically with estates and facilities on trying to close those down, and we're getting a lot of traction on that, and a lot of those are now going to be closed down. So we've got the Hodders and the Hoppers, which I'm sure nobody knows what those are. So it's hospital onset definite acquired COVID or hospital onset possibly acquired, and it depends at what point you test positive for COVID in your journey in the organisation should that happen to you. All of those have to be reported as an incident, and all of those have to be investigated. So it's a lot of work, but we are getting on top of those as well. We've put a system in place now, so we will get on top of that, and we will be able to do some learning from that. We've got our Patient Safety Week next week, so we're doing lots of exciting events next week to really raise the profile of patient safety again in the organisation. We talked about patients and complaints, and then the final thing is just around the mandatory training, which is on page 3, I think, of the report, which is maintained at a good level, which is good because we know we've done lots of work around that. And it does say the maternity risk is 25, but since writing this report, it's been downgraded to 20. So I think it was 20 in the previous one, but it's 25 here, but it is 20. We are monitoring that, and we think it will be starting to come down because we've got quite a lot of new midwives coming in, so we think that will be able to come down. So I'm happy to take any questions on that.
I know that this has been looked at in detail at Quality Assurance Committee as well. So thank you to people for that. There aren't any further issues to be raised on that. So the Learning from Deaths Q3 report, please, Magda.
Thank you, Jackie. So this report also was discussed at Quality Assurance Committee, and it just gives us some data around the nosocomial deaths, which is subject to a separate review. It makes reference to the Learning Disability Mortality Report, which Mahbub has discussed in more detail. For Q3, there were a very small number of general reviews, and that is due to a reduced number of staffing in the mortality faculty, but the faculty has now recruited a new Associate Medical Director for Learning from Deaths and additional faculty members to start increasing the number of reviews that we're able to undertake. The data is in the report. And just to comment on non-COVID deaths, we're now beginning to look again at the hospital standardised mortality ratio and the standardised hospital mortality index, HSMR and SHIMI. And just for the committee to note that these are within, sorry, the board to note that these are within normal limits. Nationally, we used to be an outlier. Other than that, I don't have anything else to add. Happy to take questions.
Thank you. Given what you outline in the report and what Mahbub was talking about in his report from the Quality Assurance Committee, can we just sort of have a little bit of a focus and a little bit of update on what we will be doing about both monitoring and addressing the increase in mortality amongst people with learning disabilities? You're on mute, Magda, sorry.
Right, that was too much of a discipline, wasn't it? So there is a detailed action plan that has been produced as a result of the mortality reviews. which ranges from a significant raising in awareness around the tools and the opportunities there are for both recognising and caring for patients with a learning disability, appropriate involvement of carers, clear decision making around patients' care, a very, very clear programme of education around the need to see somebody in terms of their treatment as independent of their learning disability, so not regarding that as a reason for somebody perhaps who may be very poorly to have a decision made around ceilings of escalation of care, for example. We are continuing to undertake mortality reviews on learning disabilities deaths, just to seek assurance that some of this learning is being embedded within the organisation. There's some additional training programmes around learning disability tool for use in the emergency department, in line with a good practice care pathway. We've got a very active learning disability team. I'm sure Catherine mentioned that, in terms of supporting teams to be able to assess patients appropriately. With learning disability training is being made mandatory. We're making sure that in terms of consent forms that they are appropriate for assessing against the Mental Capacity Act and incorporating that into the training around relevant consent. So there's a number of key actions that we're putting in place. But I think that the main one is the recognition that learning disability doesn't mean poor health, and the education programme that is around that. And that the decision making does need to be multidisciplinary, involve the patient and the family or carers appropriately.
Good, thank you, Magda. Thanks for that, Joan.
Yeah, Magda and I, we're both on quality committee, so we've talked about these issues quite a lot. It struck me, Magda, that one of the ways we could definitely think about reporting, not for the immediate term, just giving us a sense of stepping back and thinking about all of those messages that came in 2020 from Public Health England about the groups who were disproportionately dying from COVID. And over the last 2 years, we've looked at various groupings, just getting a sense of, right, so what is that telling us about now would be good, because we're dipping in and we're concentrating on learning disabilities today. And indeed, this trust in the last 7-8 years, it's really taken a very proactive stance in upping our services to learning disabilities, bearing in mind the higher community we have in Barking, Havering and Redbridge of people with learning disabilities, where nationally we have quite a big community. So we're delivering a lot more, but it just strikes me as, where do we get all of that information together? Let's look back at rightly what Public Health England said. Here are the groups that are more at risk. How do we get a sense of just dealing with all of them and putting in systems and processes? And I know that's longer down the road, but that might give your teams as well some sense of time and just time to think about where we are on this. So I do appreciate all the work that's put in. Is that something that you think might be helpful or not? Can I say no?
I think it's something that's worth taking away and considering, Joan, because there's something about, I'm going to say the word risk stratification, but I mean it, but it sounds very cold, doesn't it? But there is something about saying, you know, let's think, is this person at a higher risk for other reasons than the fact that they have got a diagnosis like a chest infection? Is there something else that might impact on their treatment and their care? And I think we do that with learning disabilities. We do it, you know, you talk to the cancer doctors, they do it for the cancer patients, but we don't necessarily do it by all of that other learning that we've had through COVID, which was there before, but just the lid was taken off. To come in, Jackie.
Okay, and I'm just going to stick a link in the chat, which is to the Ignarc reports. Now, this is some fantastic data that's been produced throughout the pandemic about the characteristics of people who've ended up in intensive care with COVID. And actually it gives you a really interesting breakdown of all the comorbidities that were involved in there. I think probably the most striking is actually BMI. with around 80% of the people who ended up in intensive care having a BMI of above 25, and a significant number having a BMI of above 30. And you know, having done a lot of work with this in my previous role, there's something about looking at healthy lifestyle choices for people who've got long-term conditions and have got learning disabilities and other issues, as well as some of the other characteristics. And really, you know, I think it's a bit of a shame that I think there was a brief period early on where the Prime Minister talked quite a bit about obesity and COVID, but then it very rapidly went off people's radars. But actually, it's the single biggest comorbidity you can find in any of the data is people who are overweight. And actually, it's one that's most amenable to public health interventions as well. I should say, having done some work on this before, though, it is something for certain groups of patients. There's something about supporting them with their lifestyles as well. And it's an issue we're really trying to get to grips with, for example, in mental health wards, where some of the medication, for example, makes it extremely difficult to lose weight. And actually, there's also factors around things like if you keep someone in an inpatient setting and don't allow them to mobilise or move, frankly, to use plain English, you know, if you sit in a bed all day and you're fed cottage pie and sandwiches with bread, etc., you will put on weight with the best will in the world as well. So there's a range of different choices and factors that play into this. But that Ignarc report I put there in the meeting chat, I have to say, I think is an exceptionally useful body of work and very interesting. And it would be a real shame, actually, if we didn't as systems take some learning from this about the conversations that we need to have with ourselves and our communities about some of their broader health choices.
Thank you, Matthew. And I'm not just saying this because Marie is in our meeting, but we did have a very good session with the North East London chairs earlier on today, looking at the health inequalities work that's happening across the system and being planned across the system. And of course, made the point that we have a challenge in the acute providers to really engage in some of those broader determinants of health, and that we have seen inequalities develop as a result of COVID, and we need to be really careful as we recover from COVID that we don't reinforce those inequalities, and in actual fact we do that in a way that helps to mitigate them. Ruth.
So I really wanted just to kind of go forward from Matthew's point of, I think in hospital and secondary care it can feel a bit more medicine centric, and in primary care I think we're seen a bit more as holistic centric, although I don't know how true that always is. And I think we need to link that up, and there's some hospitals that have taken on lifestyle prescriptions, so very much kind of formalizing that you need to lose weight or you need to become more active, and not to shy away from those, which I think often does happen, or it gets thrown in as a last minute comment of, but you know, your knee would be better if you lost some weight, and then I'm not going to do anything about it for you. There's no support. There is a lot more community support now. It would be nice in North East London if we had a tier 3 weight management, which we don't have at all in North East London or North Central London, actually. So our more complicated patients or anyone with a BMI over 40, I have absolutely nowhere to send them. And I would really encourage the board if we could look at commissioning a service like that in Queens, so that we were the North East London choice and it became a priority for our community.
Thank you, Ruth. Anne.
Yeah, thank you, Chair. And just to build on Ruth's point there, and just to assure the board that in the conversations that I've been having with each of our emerging place-based partnerships, we've absolutely been focusing on the population health and public health issues, and how we can contribute as an acute trust to support those public health issues. For example, and Catherine will be able to describe this further in terms of places like the Barking Birthing Centre, there are challenges there in terms of the health of the women coming forward to use that centre. So therefore, if we can encourage people to have healthier lifestyles, we'll be able to deliver closer to home some of our acute services. And obviously, the second thing that we can do as well is support our own staff in healthy lifestyles, as so many of them live locally as well.
Good. Thank you. Jo.
Yeah, it's a very quick one, just to come back and say, totally take on board what everybody said. We have to balance, don't we, this whole idea of access. What's your experience? We know that there is an inequality curve there. Then outcomes. And so what is it you can do to fit the outcomes as well as a medical model? Or else it almost sounds like we're saying it's your fault, just get there, have a better lifestyle. So that isn't what we're saying. And I think I just wanted to say that we're looking at everything in the round. It's about that. What can you do yourselves, as well as what can we do structurally to enable everyone to get the best possible care? Thanks.
Matthew.
Yeah, and I think there's I mean, this is where place-based healthcare really can come into its own. I remember some really good work London did years ago looking at the location of fried chicken shops around schools. It's always interesting. I always put on weight when I work in an acute hospital because I tend to eat less healthily. Even though the food on offer in our hospital is actually very good, but quite often I'll find myself accidentally stopping at McDonald's on the way home, for example, or something, because that's what you're craving after you've been on your feet. So there's something about the choices and the context we create for people. The other fact is as well, sometimes it's cheaper to eat junk as well. And we saw this, at Oxley's when we had patients out from the forensic hospital on day leave. When you allow people their own budget to spend on food, actually, it was great big bottles of sugary drinks they were often buying, because for cost, actually, that was quite a good way of just getting something that fulfills an addictive purpose as well. And so there's all kinds of broader choices in this. But if we're going to see place-based leadership really come into its own, it's not just about saying to people, you need to make better choices here. It's about enabling those choices to follow through and thinking about the affordability of those choices. And Catherine made the point earlier about housing costs and their impact on, for example, refugee families. We're in a situation where for our lower paid staff, choices about housing, food, heating and transport are all going to become a really huge issue this year, actually. And in that context, actually, all of these issues are things that place-based leadership can get together around, both us as an acute hospital, but also working with primary care, social care and local authorities who make planning choices about where we open chicken shops, etc. as well. And I think that's where the real strength of this new model of leadership and system leadership can really be found.
This is absolutely right. It is very important. It is something that we can inform, but it isn't something we're going to spend ages on in this board meeting as well. Just as my warning. Leslie.
So I won't spend very long. I will just say I think what this absolutely demonstrates is the importance of the place-based partnerships and of us playing an active role in those place-based partnerships. Because as you said, we won't solve this in a meeting here. Where it will be solved is in a forum where we've got all the right people sitting around the table talking about these things at a local level, and we should make sure we're making our input into those place-based partnerships.
The last thing you said, Leslie, is absolutely crucial, because I completely agree about the significance of place-based partnerships, and in fact Matthew's point about the larger public policy environment in which we operate. But we've got to decide what we can do as an organisation as well as part of that place-based partnership, not simply say it's and I know nobody was saying this, but not simply saying it's our partners, whether at place or at a national level, who will make those decisions. Catherine.
Thank you. I think as an aside to this, we need to think about how much we're paying our staff and making sure that we're paying them the correct amount. Fuel poverty is going to become a real issue for our staff, and that is our responsibility. I understand we might not be so embedded in the conversation that we've just previously had, but we do need to make sure that our staff are able to wash their uniforms, for example, on a high wash, using lots of electricity, because otherwise they will not be able to wash their uniforms correctly, that they are able to have food on the table for their families so that they're able to come to work fit and healthy. And I do think, particularly for our lower paid workers, we do need to start thinking about this as the fuel costs. I mean, they were just astronomical on the television this morning. They were saying what people might be having to spend. So I think that that is our responsibility, to make sure that our staff are feeling well, physically able, and able to support themselves outside of work, so that they can be the best they can be when they come to work.
Very true. Ben.
Yeah, thank you. Totally, just to add to what Catherine just shared, which I think was really helpful, and Matthew's earlier points about the cost of living exceeding the next 3 years of likely NHS pay increases, and indeed for social care, the gap being much more significant. But the key test for NHS organisations is going to be how they can recognise the bar of expectation, the reasonable expectation of how good employers we are, will rise. And so the way we think about non-paid benefits as well as paid benefits through the people framework that the PCC has been thinking about will be really, really key, particularly for colleagues where the data would suggest that gap's going to be more significant. And clearly, in the main, that will be lower paid colleagues. It will be for women. It will be for people who've got caring responsibilities, who are living by themselves. All of the equality characteristics thus must guide our approach too. And to a degree, the way the ICS can brigade commonality in our thinking will be really helpful too. Because what we won't want to do is go out and shoot out with specific initiatives that create further inequity and inequality because they're distinctive unnecessarily to those of partners.
And notwithstanding what Catherine said, which I absolutely agree with, compared to some other employers, we are good and good, well-paying employers. So the work that we do to promote employment as anchors institutions more widely in that area is also going to be significant here. Right, good. I fell into that trap as well then, didn't I? But I think it was an important trap to fall into, given our responsibilities to ensure good health, not just good treatment for our patients. Anne. Right, let us move on appropriately to the People and Culture Committee report, and Leslie, you're going to introduce that.
Yeah, so just a quick introduction. We had a discussion on the people framework, which I think is a really important cornerstone of how we're going to develop and work on those people issues over the coming years. We looked at 4 of the 6 elements on education, learning and development, and modernised employment practices and wellbeing. And it was really good to see that those have all been developed and informed with contributions and input from the staff networks, the trade unions and partners. And I think there's a real opportunity to explore the connection between education and a community engagement strategy and be much more explicit about our role as an anchor institution as an employer. And I think just looping back to one of the conversations we were having earlier about people with learning disabilities, we talk, and it's discussed when we talk about the corporate objectives about us employing people locally. I think there's also an important role for us in supporting people with disabilities into employment. So the general employment rate, roughly speaking, for people with disabilities is about 52-ish%. The employment rate for people with learning disabilities is half that. So it seems to me that there is a role that we can play in supporting people with learning disabilities and supporting people with disabilities into work, because that feeds into that generally making people more independent and more a part of the community that they live in rather than apart from the community that they're living in. We're going to get the next iteration of the people strategy in April, which will be important. We had the medical education report, and on International Women's Day, not terribly encouraging to see that one of the findings that came out of that is the sexism that's been experienced by some of our trainees, and certainly something that we know that we've got to address as an organisation. I hope people have looked in the report and seen the infographics that the staff networks produced, which I think is a really good representation of the achievements in 2021 from across the trust, and people have been really engaged and involved. On recruitment and inequalities, there still is, Joan Mahbub and I are slightly broken record about this, but there still is a disparity in terms of recruitment. If you look at Agenda for Change roles, the ratio is about 4:1 of white staff to BAME staff being appointed. And it doesn't start with, we start more even, and as the process goes on, the gap widens. There is still a lot to do, especially on making sure that panel members have actually undertaken recruitment training. And I can remember, it must be well over 2 years ago now, because it was when we met in person, Linda and I sitting muttering to each other, because Linda used to be the director of HR when I worked in local government many years ago, muttering to each other about we couldn't believe that people weren't doing recruitment training, because we'd made this mandatory 20-something years ago where we worked. So I think there is still a lot to do in terms of panel members actually having training and making sure that although diversity partners are on those panels, that those diversity partners are taken seriously on those panels and are given an equal role and aren't there just to make the numbers up and in a tokenistic way. And I know that isn't the case on all panels. I suspect it's still the case on some panels. And then finally, in the Guardian of Safe Working report, again, looping back to the discussion on IT earlier in the agenda, something that was picked up in that report about our slow and unresponsive IT systems. So again, as people have said earlier, that's an area that we know we need to focus on because it impacts right the way across the organisation. And I think the appendix, there is the terms of reference just for, I think, formally agreeing.
Yes, there are, Leslie. George.
Thanks, Jackie. Yeah, Leslie makes a valid point about EDI. Recently, I've altered. Our EDI question was, could you recite the pride values? Which I don't really think gives you a good sense in terms of whether someone's really living the values. So we've adopted a far more structured approach in terms of asking people to explain when they've seen poor behaviour, what they've done about it, how they challenged it, next steps, etc. So I think we have moved that on, thankfully, from what I would call a very old-fashioned and unproductive way of flushing out EDI at the panels. Thank you.
Thank you. Linda.
First of all, thank you, Leslie, for reminding me that it's a very long time ago that we worked together. And yes, you're absolutely right. We did mutter about how, I'm surprised how far behind the NHS was in terms of equality issues. And I think that you're absolutely right, George, in terms of, I think many times the EDI questions have been a bit sort of, well, OK, we've got to ask this question. And people can actually learn because they know they're going to be asked a question about this. So they actually have a sort of stock response. And I think you're right in actually trying to talk about their experience and what they have actually positively done to change things. And I realise that's probably outside my role for being here today. But what I would say is, again, for many years of recruiting many people across a number of organisations, the one thing that's always struck me is that if you have good, well-motivated, representative, a group of staff, what you get is a better service for the patient or the service user, whether it's police officers or local government officers, whatever it might be. What you get is a better service. And I think that's the thing where I'm coming from, that if you are able to have a proper recruitment process which ensures that you get not only the most appropriate person for the job in terms of their skills, but their understanding of the way the organisation works and actually functions, and in an equality way, then actually what you get is a better service for the patients. And clearly that's where my particular interest is. So I don't think there's any sort of, there's no difference between getting the right person for the job and the benefit of the patients. It's actually all part of the same whole. So I think it's very, very important that we ensure that we get the right people. And I think that one of the things about recruitment is also making sure that the patient experience bit is woven into questions on recruitment, because that's what we're in. You're in a service organisation where the patient is centred, should be patient centred. Thank you.
Absolutely agree. Right, Jackie.
Yeah, thank you. I just wanted to make a link between the point I made from the quality committee, where I said that there was a sense that staffing was an issue across a number of the reports that we received, and your feedback from the Guardian of Safe Working Hours into the People and Culture Committee, and this comment here about 72% of exception reports quoting understaffed wards being the reason for excess hours worked. Just good to get a sense of, do we think, you know, we don't have enough staff? Do we think the staff are in the wrong place? Is it due to sickness? You know, just sort of any sense of what's going on here, because it's, you know, it's clearly come up in both of the committees.
I think Jackie is absolutely right, and there is a theme that has been noted of both increases in the number of staff that we have in the organisation and concerns around the limits on our ability to develop new services or even operate the services we've got at the moment because of shortages of staff. And I think it would be something, it would be worthwhile for the board, perhaps not, we can't necessarily do it today, but I think it would be worthwhile for the board as a whole, as well as I know it's come up at Finance Committee, to explore a bit further so that there can be some assurance around where our staff are being deployed and how they're being deployed to ensure that they're meeting our priorities, particularly around quality. Remy.
Thank you, Jackie. Happy Women's Day to everyone. I wanted to just reassure people from an EDI perspective, because we're quite surprised when we found out that the questions were centered around pride values, that we have a repository of questions and creative questions as well that we evolve and develop that people can use. We use these questions with our diversity partners, and we offer them freely to anyone who doesn't have a diversity partner to take to the panel and use as well. I also want to point out that it's been a long time coming, the new recruitment and selection policy, and I've sort of said it's a bit like being pregnant, being an elephant who's pregnant. It's taken a good year for us to work on it, but it means that it's unearthed things that we weren't aware of before, i.e. the recruitment training. And what we have done is discussed with our counterparts in recruitment how we can best increase the number of people who get recruitment training as well as AAC panel training. And we have a renewed focus in ensuring that the panel is properly updated and trained and ready to sit on the panel. The other thing is about empowering our diversity partners. So we are getting to the point where we want our diversity partners to be able to speak up and say yay or nay in terms of the fairness within the panel, and actually escalate if they do have a concern.
Good, thank you. Joe.
Yeah, just a couple of comments, and the first is, I suppose we all have our areas where we feel more comfortable when we talk about equality, diversity and inclusion, particularly when it comes to recruitment. So I would just encourage us to look at what is it our trust really needs, where do we need to prioritise, and there are some really clear, not just signals, but mandatory targets, outcomes that we should be reaching. We do talk about them, but maybe those will focus us as to what really is going wrong and what we need to put right. And just the workforce disability scheme and the workforce race equality scheme are just two examples, as well as a gender pay gap. So we know it's easy to fix some things than others. That encourages us to look at who our workforce is. They're very diverse in all kinds of ways. And are we really meeting their expectations about where they should be in this organisation? It's quite difficult, but actually with focus, we know other organisations have done that. I think we can do that. And the second point, I suppose, is in the narrative from the chair. That shortlisting and what is happening at shortlisting is quite damning for us. So we're starting to get it right, more right. Because if you look at the paragraphs that talk about what our recruitment processes look like, we're starting to get it more right. But I think we just need to continue that focus on really drilling down whether it is BME, whether it is women, whether it's disabilities, not choosing one or the other. And I'm saying that because I work nationally in this space where, back to what George said, experience-based practices, what have you done? Can you show? Who have you led? That's where the evidence tells us we get a better granulation of answer in terms of what people can do. So just encourage us to go down that route. Thanks.
Good. Okay, good discussion. We will move on now to the planning section of the agenda and to the organisational objectives for 2023, which board members will remember we have discussed the process has involved us discussing this at a seminar and discussing it at board in terms of determining what we wanted to focus on in terms of our objectives. So we're coming to the sort of latter stages of a process in which there's been quite a lot of engagement and discussion so far. And Anne, I think you're going to introduce this. Thank you.
Yes, thank you, Chair. So yes, today, following on those discussions, we're now here to seek approval of these corporate objectives from the board. What I will do is hand over to our colleague Lee Basso, who's been deep in developing these and working through these, and therefore I think it's fair that he presents the final version of these to the board, and then I'll just finish with a few words just in terms of implementation. So with your permission, Chair, I'll hand over to Lee.
Yeah, great.
Yeah, thanks, Anne. Good afternoon, all. So yes, hopefully this is now the home straight. So presented are what hopefully are the what will be our corporate objectives for next year, and as we referenced, they will look fairly familiar to most of you now, to the board members, given that we have discussed this through the board development seminars and through our executive committee forums. So so what we've done since we last spoke is we've taken on board the comments, we've incorporated those changes, and hopefully these now reflect those conversations that we've had previously. I think it's worth noting that as we've developed these objectives, we've tried to incorporate the planning guidance where appropriate, and also start to reflect on where we're going to be moving in terms of next year, and that is to more of a business as usual environment, but equally think about how we recover our services and indeed increase the focus on our staff and their well-being. The objectives also look to anchor ourselves as a significant partner within our communities and sort of chimes with the earlier conversation around place-based partnerships and indeed the developments that are happening at the ICB. So hopefully what we've been able to capture within these objectives are lots of what's happening around us, as well as what we need to focus on next year. You'll see in the pack that I have made the deliberate point that these objectives are framed in the absence of our clinical strategy and indeed organisational strategy. So we'll need to reflect those at a point when they become kind of more developed and signed off. So in terms of next steps, what we will be doing is embedding these objectives within our planning process that again we have discussed previously with the board members. We'll look to embed these objectives within our local conversations. So how do they help frame our individual and team-based objectives? And then we'll look to start to use these objectives within a broader conversation on how do we create an environment that helps us as BHRUT create an environment for success. So I'll probably pause there and quite happy to take questions, or if Anne, you want to bookend that.
Yeah, so just to build on those points, Lee, and thank you for that. Yeah, so this work will be paired with our business planning work. It will be paired with the rollout this year of My Conversations. And one of the things we want to do is to really focus our improvement support around how we deliver these objectives and our business planning objectives, so that each of the divisions feel as if they are fully supported in terms of making this happen. And then I guess there's just a question for us as the exec team in terms of how we create that environment for success that Lee was creating, and then more broadly as a board, as well as assuring delivery against these, how we as a board create an environment for success. So I think that what we will be doing is creating some time for us to have that discussion. And I just want to take this opportunity to thank Lee for his ongoing work on this, which I think has been great. So thank you. So yeah, happy to point any questions to Lee.
Linda, you've got your hand up, but I think it might be a leftover hand. Yeah, okay, good.
Find the.
So, thank you, Leslie.
Just to say, I'm really pleased that in the section where we talk about being a proactive contributor in the local economy, we have actually now got a specific mention and target in there about enabling local people to take up work with the trust. And although not explicit, can I assume that in light of the conversation we've had and the conversation that's been going on in the chat, that we will ensure that we try and make sure that we provide some opportunities into work for people with disabilities, and particularly people with learning disabilities, as a part of that piece of work?
Yes, absolutely.
For people who are able to multitask and read the chat at the same time as, in my case, chairing the meeting, I did nevertheless note that there was a good chat about Project Search, which also exists at Arts Health, and Remy was talking about us working to try and develop it here, which is providing placements, work placements in particular for people with learning disabilities, which would be a great initiative. Good. Ben?
Yeah, just to say, with thanks to Anne and Lee, we're going to move really quite quickly now to put in place a new modernised approach to appraisal, which builds on the approach we had last year, which is focused on health and wellbeing and equality and equity. That evaluated really strongly with staff. We had over 2,000 responses from staff talking about how 91% of them regarded it as an advance on the former year, and over 85% of them said it was really positively focused on their health and wellbeing. So what we want to do is make sure that process is in play from early in the financial year rather than the autumn or winter as it was last year, so that we can make sure that the objectives have meaning to colleagues and we're thinking about their health and wellbeing really quickly in the spring, alongside the people framework. So the next PCC will take the people framework, the people and culture committee will take the people framework and a line paper on how we can make sure the conversation process begins well from April onwards.
Thank you, Ben, for the PCC explanation. Not Police Crime Commission, not anything else. Catherine.
Thank you. We do quite a lot of work in the organisation with adopted children, people with learning difficulties, people coming out of the care system, people coming out of the judiciary system. And I've got a new Director of Workforce, one of my deputies is going to be specifically on workforce. And one of the things that I've asked her to do when she comes in is to collate all of the schemes that we've got and all of the programmes that we're running to come to people in OD, because I think that the board is not well cited on the work that we're doing, and actually we are doing a lot of work which is being recognised outside in a way that I think the board perhaps would not be able to articulate. So I hope that would be helpful. We're hoping to bring that to the next People in OD committee for wider sharing.
Thank you. And do you just want to reiterate the steps for people, so that we're clear? I think you said it, to be honest, but so that we're clear about where this now goes and what we will be doing to the actions that underpin it.
Yeah, absolutely. Thank you, Chair. So, the first step will be approval of this board of this set of objectives, and then from there we will do a number of parallel activities to embed these across the organisation. So the first thing will be to discuss them as part of our business planning workshop with the divisional leaders that we have planned for the 3rd week in March. The second thing that we'll be doing is working with Ben and the team just to make sure that the objectives are embedded in the My Conversation approach. And then the third thing that we will be doing is taking some time out as an exec team, and part of that conversation will be about how we create an environment for success to embed these. And then the fourth and final thing will be, how do we revisit these and make sure that they know that we know that they are being delivered and that they are working, and therefore, and then come back to the board to discuss that. So those will be the 4 key steps.
Great, thank you. Matthew?
Yeah, it was just to say that, you know, developing objectives like this in the absence of a strategy is hard going, and Lee has done a superb job getting us here with these. I think it has been a grind, I think, to be quite honest, because I think we've all had different views and perspectives on how to get through from where we were to where we are in the absence of a clear strategic roadmap. And that next year, as we say, by the time we come to this, we will very much have that strategy, if not in place, very much ready to launch, I think. So it's just to say thank you very much to Lee for his efforts to get us to where we are.
Thank you. And I was going to say that as well, not least because I remember the first meeting where Lee had to try and corral us into coming up with something. So thank you very much, Lee, for all of your efforts on this. And I think we've ended up in a good place. Jo?
Yeah, I just want to say that I think all looks very good. I think the one thing that's probably missing is playing into our plans around health inequalities and being a bit more stated about that. So that doesn't just have to be in one section, because you've already got stuff there in relation to maternity, for instance, Lee. So I think there's something about finessing our absolute aspiration to want to tackle and be that system partner we just talked about in the previous discussion, but just tailoring some of those things that actually will help us tackle inequalities, whether it's sepsis, whether it's the learning disabilities stuff. Let's tailor it a bit and be quite stated in there around the objectives. Thanks. And it's a great piece of work. Thanks, Lee.
Good point to finish with. Let's move on. Thank you for the work on that. To the finance and operational performance section. And we start with the committee report, George. Thank you.
Thank you, Jackie. To recap for the board, our ambition was to exit with a deficit of 5 million. And last month, our deficit was running north of 6. So we do not believe we will be starting the new year with a 5 million running deficit. So there's some risk around that. We've seen an escalation in rates in agency and bank, and also a decline in our theatre utilisation. We approved, and there was quite a lot of discussion around the 400 additional people that we've taken on board. And some work has been done with Alan Wishart and his team to really get a deep dive into that and to see how much of that can go once we eventually get rid of COVID. We approved digital investment, PACS image sharing, and a desktop refresh. And we recommended to board the electronic prescribing and medicines administration, the strategic outline case for the community diagnostic centre for BHRUT, and the ED investment in converting bank and agency staff to permanent. To summarise, a very difficult month for the organisation. The challenge will be to get, I guess, to recalibrate the plan to make sure that we get the right people deployed to deliver it, particularly around waste and theatre productivity and agency and bank. They continue to be our 3 major areas of opportunity and challenge. Thank you. Happy to take any questions.
Thank you, George. And that links in, I think, to the point that we were making previously about the additional people and the deployment of them as well. Yeah, it's a sort of theme, isn't it, that's emerged from your report and the Quality Committee report that Jackie was outlining. Good. Integrated performance reports. Richard, I think you're presenting this.
Yes, thank you, Chair. Can I just check you can hear me okay?
Yeah.
Thank you very much. Just to, I suppose, reference the point that whilst this sort of feels like ancient history, actually this performance report reflects January performance for ED, RTT, diagnostics, and December performance for cancer. So I guess that's a period of time when we had nearly twice the levels of staff sickness we had at this point, and much higher numbers of COVID patients in our hospitals. So I suppose from context about where we are now, our overall COVID numbers continue to reduce, although it's worth recognising we still have a number of very poorly patients in our, particularly in our respiratory wards. We're still applying the infection prevention and control guidance as before, so that remains a constraint operationally. I suppose, as you've heard from Matthew in his introduction, as the COVID prevalence has decreased, we have been able to convert some of our spaces to use them differently, and in particular the enhanced same-day emergency care pilot that we started on Monday. So I mean, it's having some immediate practical implications. So this is managing patients in a slightly different way to pulling patients out of ED. So 17 patients yesterday were managed in a different way, and that in turn creates capacity to improve, hopefully improve ambulance handover times. I think it's also worth adding from a staff perspective, it's adding a real buzz. So we're doing something innovative. They feel like they're making a difference. So I think we can't lose that benefit as well. Again, Matthew's referenced some of the other areas. So the ambulance receiving centre has been up and running for sort of 3 months in some way, shape or form. And I think we've saved in excess of 2,800 hours of ambulance crew time through that initiative and that innovation. And added to that, we should be having additional beds coming on stream at the early part of the next financial year. As far as elective is concerned, so I guess the drop in activity that we saw in January, partly as a result of staff sickness, additional staff leave, but also large numbers of COVID cancellations. So that resulted in firstly a growth in our waiting list, and secondly the fact that our 52-week performance remained static from November through to January. So in order to try and address that, we're extending our use of the independent sector, but also bringing in additional capacity, particularly at weekends, to address some of the services with longer waiting times, larger waiting lists. So I guess in reference to the objectives we just discussed, our plans for next year place a big focus on patients in our waiting list who are waiting for outpatients appointments and diagnostics, so not just the theatre component. So it's important that we cover all of those bases in terms of our waiting list size. The final points just around kind of, I suppose, plus points. We're starting to see good improvements in diagnostic performance, and this is particularly a result of the good work that's been seen in imaging, both in terms of creating additional capacity, but also improving booking processes. So that's really good stuff. Our faster diagnosis performance was met for the third consecutive month. It also means we were compliant for that quarter for a sector for North East London as well. But finally, we're starting to make good headway in terms of the patients on our cancer waiting list that have been waiting more than 62 days. So the intention is to halve that number by the end of March. I'll pause there and happy to take any questions.
Ruth.
Hi, thank you. It was a great report. It took me ages to read it because it's got a hell of a lot of detail in it. The question I had was about, and I know we keep talking about agency staff, bank staff, and there's a lot of problems also around that, and it is more complicated. Is there room for looking at trying to convert our bank staff into kind of salaried staff, but by doing so over-employing? Because ultimately that would still create a saving because we're not paying the bank or the agency extra fees, but also it would have for well-being for staff, because I know a lot of the staff feedback constantly that they feel they're always on the edge of staffing, and we talk about at board level and all our other committees of there just isn't the manpower, and really just getting those authorised a little bit quicker so we can make some rapid changes. I appreciate there are some staff that only want to do agency and bank, which is always difficult.
Richard, although I think I'm right, aren't I, that one of the challenges is that many of our bank staff are our salaried staff.
Yeah, so I suppose I'll answer that a couple of ways. I can see Nick and Matthew both got their hands up. I'm sure will want to weigh in. So I guess I'll talk purely from an elective point of view. I think what we have learned from some of the work we've done through the Blitz work is actually the teams are happy are actually motivated to work in I suppose short bursts to do extra activity on the expectation that they'll get a bit of breathing space afterwards. And I think Matthew was pointing out that when he's spoken to the staff, actually there is a sort of a kind of knock-on effect for weeks afterwards. So it actually does kind of raise the mood and raise the motivation, because it actually feels as if you're doing something positive. So I think that's a factor that can't be lost. Certainly as far as our bank and agency savings plans are concerned, a lot of that is predicated on converting at least agency staff to permanent, but I guess that relies on those staff being available in the first place. So that's the kind of challenge we'll have, and we'll only work that out as we start to get through the kind of specialty level detail.
Nick.
Yeah, great. Thank you, and afternoon, everyone. I think, Ruth, we're trying to tackle it in a couple of areas. Firstly, we're trying to tackle sort of pay inequalities. At one end, we'd like to make sure that everyone, whether they're subcontracted or not, gets the London living wage, which hopefully will mitigate to some degree inflation. At the other end, we do have some very high earners, many hundreds of thousands of pounds in some cases, which we need to just level up. It's just not right to have two people working next to each other with such a gap. And so there's an awful lot we can do on the rates, first of all, part of which is to build the substantive workforce. On your point about employee numbers, we do have about 1,000 employees more than we did a couple of years ago, largely medical, about 250, and nursing, about 500. I think ultimately there's a pathway redesign opportunity there, probably across the whole system actually, which is going to be the real way to optimise the establishment. So a couple of thoughts for you on your question.
Thank you. Had you finished, Richard? And if so, are there more questions on the integrated performance report?
Yes, I had finished, Jackie. Thanks.
Okay, let's move on to the finance report then. I think Mike, are you presenting this?
Yes, Chair. Yes, thank you. Afternoon, everyone. I'll be very brief because I think between George and Nick and the previous conversation, I think most of the content's been covered. But worth noting that we, despite the underlying run rate challenges, we are on plan this year as we stand. We're $1 million ahead, and we're forecasting to be on plan at the end of the year, and that's inclusive of all the COVID and the winter money. But as the conversation's just been had, let's not lose sight of the underlying position, because it indicates the waste in the system that we can take out. On the capital side of things, we have 45 million available to us, and since the report was written, we've now moved on, and we have business cases and governance in place for all 45 million of the capital. So we are hopeful and expecting of spending that money by the end of the year, despite the challenges that the system throws at us. The cash is reasonably strong, so whilst we remain on plan, we will continue to pay our suppliers on time, so about 93% paid on time. I won't go over the other points, which were largely around banking agency and elective, which have already been covered.
Any questions or comments on that? Okay. Audit and Risk Assurance Committee report. So.
Thank you, Chair. Let me just get to it. So the Audit and Risk Committee has met once since the last board meeting, and that was an extraordinary meeting to receive the charity accounts and audit report. The report sets out pretty clearly the process that we went through, and actually we engaged with board partway through that process. I am pleased to report that we were able to file our charity accounts by the deadline. having had discussions with the auditors about the wording of what I would call a technical qualification. So we achieved a satisfactory outcome. I think it's fair to say that we owe a duty of thanks to the auditors for a very robust audit process, which concluded on time. And also I'd like to say thanks, I hope on behalf of the board, to all of the staff involved in accounting for the charity, and to George and the trustees for leading it. But that was the only matter that the committee considered. So obviously, any questions, happy to take them. Thank you.
Thank you, Sue. And I would reinforce your thanks to all those involved in getting those accounts with, as you say, some quite sort of rigorous questions that related less to the current accounting situation and more to the accounting of previous sums of money received. So thank you, George, and everybody else involved in that. Good. Okay. That brings us to risks identified during the meeting. I think we will, Linda, I think you've probably made some notes of some of the things that we've identified as we've gone along in terms of, and my feeling is that probably we've had quite a good discussion about most of the things that we've identified, although I do think there is probably, although it is identified in our BAF, I think there is a further discussion to be had around some of the issues as we've identified to do with finance and staffing and the relationship to quality and our priorities. Is there anything else that people feel it will be, we really need to sort of flag up as being something we would want to pursue? Okay, let's move on to any other business. Has anybody got any other business? Let's take questions from the public then. So if you are a member of the public and you would like to raise a question, now is your opportunity. Andy, I think you're keen to raise one. You didn't ask in advance, but you have tweeted about it, so I presume.
Oh, yes, I've been naughty today on that, Chair. Thank you very much for indulging me. It's I just wanted to pick up on the points Matthew made about beds. Just for clarity, how many beds could Matthew open with the funding that he has? And if he has any opinion about if BHRUT problems, if that's symptomatic across London or other hospitals unable to open beds in London as well. Is this a growing trend? It's a cause for concern. And finally, his best estimate of what would happen to the 4-hour target if he had the A&E 4-hour target, but especially the type 1, if he had all the beds and the staff that he's got a budget for, please.
Matthew.
Yeah, thanks, Andy. So within the Queen site, we have the potential to open 30 beds, which we wanted to use as an acute assessment ward. And at the minute, based on our current staffing estimates, and Catherine will correct me if I'm wrong on this, but I think we've got enough staff probably to open to 10 beds from later this month. And so where we could have 30 acute assessment beds with a relatively short length of stay, and that would be helpful with pulling patients through ED, we've got enough staff for 10. And there's also a further community ward that North East London Foundation Trust run as a stroke step-down ward, and that was due to open to 15 beds in January. That still hasn't opened due to lack of nursing staff, and may open in April. And the impact of that is that we roughly have at any time between 8 and 12 patients in our stroke beds who could be cared for in community setting for stroke as part of our step down. That means that we're not able to move patients through the emergency department into the hyperacute stroke unit pathway as quickly as possible. And we've seen our SNAP and the stroke audit scores decline from the highest A grade down to a lower level in recent audits because of the pressure that lack of flow is having on there. Overall, trying to quantify the impact of what would be effectively an extra 40 or so beds for the emergency pathways, You know, we're talking a couple of percentage points. It's not game changing until you really change some of the assessment models and the pool models, but our performance would start consistently with a 3 rather than a 2. I think in terms of type 1, it'd be in the 30s rather than the 20s as it has been recently. And certainly for some of those pathways around stroke, it would make a really quite significant difference. So, is it a growing problem? I think it is a problem that other trusts, particularly in Outer London, do report across London. And it's interesting, I think, throughout the board today, we've heard that joint narrative of financial pressures, but also staffing pressures as well. You know, these are real difficult things, and I think that's why there is such interest in the Secretary of State's commitment to workforce planning for the longer term in the NHS. I should say, as a trust, we do some excellent stuff at looking at other career pathways, you know, recruitment of people into roles like physicians associates, alternative nursing pathways, increasing things like our ward clerk contingent, because we need to recognise that actually continually chasing, you know, going out to advert time after time after time for posts where we just know there isn't a field there is a waste of time. You know, we've got to design different models of staff, but it's a big challenge for us and a big challenge for the NHS nationally, with I think over 110,000 vacancies nationally at the minute, and which tend to be concentrated in similar areas that all trusts are chasing.
Okay, thank you very much for the detailed reply.
Randy, are there any other members of the public who would like to ask any questions at this point? No? Okay, good. Well, can I thank everybody for today's meeting, but particularly can I thank Magda. It is Magda Smith's last board meeting today as our Chief Medical Officer, as she's leaving the trust at the end of March, not leaving the collaboration because she's going to Barts to be the Deputy Group Chief Medical Officer. Magda, I know that you've had a long and very important relationship with Korea and time at BHRUT, and on behalf of the board, can I just thank you very much indeed for the contribution that you've made to our patients, to the quality of the services that we're providing, to your medical colleagues. As people are saying in the chat, we will miss you a lot, but we are assured that you're still in North East London and connected to us by the collaboration, and I know that that will be a really good way in which we can make sure that we continue the good work between us and Barts. And it's okay for me because I get to see you on the other side of my job as well. But on behalf of the BHRUT board, thank you very much indeed, and very good luck for the future. And you will, of course, always be welcome at BHRUT and always be an important part of us and our work. So thank you and very good luck.
Thank you very much, Jackie.
And Matthew.
Yeah, and I'll just largely repeat what you've said, Jackie, but Magda's been a joy to work with since I joined the trust. She knows the trust so well and is a really important part of BHRUT, actually, including what she did during the pandemic. You know, but I've thoroughly enjoyed working with her. It's a shame to see the Scottish contingent within the executive team watered down slightly, but we'll manage. But she's you know, as a colleague, she's been wonderful, and I very much look forward to working with her as a partner through the collaboration at BART, and it's very much to their benefit to have her as part of their senior leadership team. Thank you, Magda.
Thank you, Matthew.
So Magda, thank you for your more than 25 years service. And thank you everybody else for your contribution to today's public board meeting, and some of us will reconvene for the private board meeting after you've got a cup of tea. Lovely. Thanks very much, everybody.